I am just very, very pleased to be here with you today and to be able to talk about these major kind of changes that are going on in the healthcare industry and how we try to address these and how we should be looking at these initiatives as we're trying to move forward, advance our various organizations, so that we can improve quality, access, and reduce the cost of care. So you might ask, how does a guy go from, a provider to a health plan, And, I did a piece on myths and realities recently around ICD-10 and payers. And I had some preconceived notions when I went to work for a payer, okay? I had some, a little bit of worry about whether I'd be able to do the things I like to do as a professional. And I have to say, I always love coming back to a facility like CHOP or any other facility and engaging with folks that are closer to the action. But it's interesting, we're talking about informatics. And when I was at Christiana Care on my team, I had 3 nurses who worked in informatics. Now I have 2 on my team at the health plan, okay? When we talk, a lot, when I go to a leadership meeting, a clinical leadership meeting, I'm working with physicians who are concerned about the care for the patients who are members of our health plan. And so while, yes, health plans and providers butt heads, we really probably have our values and our strategies aligned about 99.9% of the time. And so what I do today for the health plan is I do almost the same thing that I used to do when I was in the provider setting. I'm involved in trying to get the right information to the right person at the right time in a secure way so that we can ensure that quality and access to care is provided for that member. In our case, 5 years ago at Christiana Care, it was a patient. So it's not that different in some ways. Okay, so let me get into the kind of the talk here a little bit. AmeriHealth Mercy, most what you really know us as here in southeastern PA is Keystone Mercy Health Plan, the largest Medicaid managed care organization in the state of Pennsylvania. Around 310,000 members here in southeast PA. We also run a health plan out in the Lehigh Valley, which was closed today because of the flooding out there. And then health plans in Indiana, South Carolina, New Jersey, Kentucky, and soon to be Louisiana. So all managed care plans. So if you aren't familiar with the model, what states frequently do now is a contract instead of having a fee-for-service kind of arrangement. They contract with organizations like ours, okay, and we sometimes on a risk basis, okay, so we might get paid, I couldn't tell you exactly what the amount is, but it might be, let's say it's $20 per member per month, okay? And then we figure out how do we deliver the right kind of care to that person and meet the standards and so forth. In other cases, there are other different kinds of methods. But that's what I do. That's what the kind of organization that I work for. We touch about 4 million lives nationwide. I think what my kind of area really tries to do is we try to support our care managers, or the folks that are working with the providers to deliver, to make sure we're all working off the same page from an information standpoint. So that's our goal. Today we're going to talk about unfortunately, I'm sorry, I know it's touching a nerve today, the perfect storm. I know there's no such thing, but from about a couple years ago, I did a presentation on this idea of the perfect storm in HIT and all of the kinds of initiatives that were being advanced and how these are all coming together at the same time. So we'll talk about that, how these actually, although they came from different places, how we can look at them in a more holistic way to try to integrate them and chart a course that really does leverage the assets that each organization has to apply to these sometimes federal mandates, sometimes business mandates, organizational mandates that we're all facing. So this is the original perfect storm slide done a couple years ago, and you can see we have top of the list there is 5010, new transaction standard that comes due at the end of this year. ICD-10, which we'll talk about today, which goes into place on October 1, 2013. We have high tech, or EHR Meaningful Use, as most people think of it as, but it came out of the High Tech Act. And that was stage 1 that started in 2011. Stage 2 at that time was scheduled to start in 2013. We'll see where that goes and talk about that a little bit. In stage 3 in 2015. And then you have your business initiatives, the things that your organization here at CHOP wants to achieve, okay, in terms of how you can improve patient care and achieve your organizational objectives. So now we look at this kind of storm again, and it's continued to brew, and we see some changes, some new things, some differences that are going on. First, we look at 5010, and today we're not as far along on 5010 as we would like to be. Probably CHOP is, probably many of the major facilities are, but there are a lot of folks out there today who are having real challenges keeping up with 5010, and we're going to have a challenge meeting that deadline at the end of the year, where every transaction on 1/1/2012 needs to go in 5010 format. That means a claim, it means an eligibility request, it means an electronic remittance device. All those HIPAA transactions change to a completely new format, and if they're not in that format, they will be rejected by a health plan or a clearinghouse, depending on who you're submitting to. We have ICD-10. So one of the things there, you see that little arrow that goes out a little bit far. One of the things we need to think about is, we'll come back to this, is many of you probably were involved in the last, what I call kind of HIPAA-related major change, which was the NPI. Okay, we still in our health plan today have meetings and talk about problems with NPI. Okay. And NPI did not end as an initiative on, I think it was May 24, 2008, okay? There's a long period of stabilization. There will be a long period of stabilization for 5010, and we can be sure there will be a long period of stabilization for ICD-10. So the executives in the room, who are on the phone, or who might be listening, when you see that there is a go-live point on these initiatives, don't believe it that initiative is over at that point. It's going to go on for a while because we never get these things perfectly right. They're too complicated. There are too many people involved. And we learn after implementation some important lessons that have to be applied. And stabilization takes quite a while. Health plan and provider. Not pointing at providers. Health plans have challenges too. High tech. Okay, we have stage 1. And I'm sure that there's a lot of focus here on stage 1. Stage 2 looks like it could get moved. Okay, we'll come back to that a little bit later. We have health reform that went in, and this creates a whole bunch of issues for us. We've got health insurance exchanges out there. We've got these operating rules for HIPAA transactions that are going to be around that were created for health reform. We'll get into that a little bit later about what those are, but those are real important because they're going to require big changes on the payer side and maybe some pretty nice opportunities on the provider side by creating better consistency across how the various transactions are used. And then we know that there is also an accounting for disclosures. I think it's a interim final rule, probably not. I think it's probably a proposed rule at this point that there's a lot of concern about in terms of how are we going as providers and health plans, which applies to health plans as well, comply with these accounting for disclosures components. There's changes in how we pay today that are enormous and changing our landscape. There are a variety of other things, but this is how this storm has kind of brewed over the past several years and continues to brew. Okay, so what's the result? One of results of this storm, there's an unprecedented level of investment in healthcare IT, okay? All the other parts of the economy are kind of dipping down. You know, healthcare IT, I think, read recently, in basic research in healthcare IT, $200 million last quarter was invested in that. So, and this continues to be a very hot area with a lot of vendor involvement, a lot of new investment out there in healthcare technology. Unprecedented changes are being created by this storm for providers, practices, facilities, and health plans, okay? We're all facing enormous changes that we could never foresee, looking 5 or 10 years ago. There's an unprecedented risk of failure, okay? There are so many changes going on. These are critical pieces that cannot be ignored and will potentially have an impact on an organization in terms of making it not feasible to exist anymore. We see certainly a lot of consolidation in the physician practice area. Small physician practices faced with such enormous initiatives as EHR Meaningful Use, ICD-10, just go down the list, and payment reform, P4P, all of those things, are having some challenges there. There's a lot of consolidation that's going on in that space. But there's also an unprecedented opportunity for success here. Look at all of these investments that are being made. We don't need to go out and convince folks that they need to so much invest in electronic health records any longer. Okay, people pretty much buy that. When I started at Christiana Care in 1995 and then started their EHR implementation project in 2001, there was a lot of convincing to the board that we needed to make that investment at this point. Now, I'm not saying that we don't have to justify how we make these investments and are they prudent and what are they delivering to our business from a value proposition standpoint. We definitely do. But it's not as difficult as it was to convince people that these investments are important, and in fact, in some ways, critical to maintaining or improving competitive advantage in the healthcare marketplace. So, lots of opportunity for success here, I think, for organizations both on the provider side and the health plan side, who can look at these various initiatives and figure out how do I convert them from a problem into an opportunity, and how do I make them work together so that we can effectively deliver in a cost-effective way the change that's required as a result of these. So, it's a very, very exciting time. So today we're going to talk about some 5 big HIT initiatives. ICD-10, EHR Meaningful Use, Operating Rules, Health Information Exchange, and Health Reform. We're going to talk a little bit about what each one of these are. I won't spend a lot of time on them, particularly ones I think you know a good bit about. And then we'll come back at the end and we'll talk about how these 5 initiatives, which really all originated out of completely different or developed on completely different paths, how we need to start to see them as or look for those opportunities to integrate them as we move forward and try to leverage them to improve, the business, that we're in. So ICD-10, I think many people can work better together. And I know that there's a lot of information and a lot of progress being made around ICD-10, a lot of thinking and analysis that's going on here. So, a huge change in the way the code set is handled. Many organizations see this as the Y2K of healthcare. Okay, it's going to change everything. Okay, so I'm not sure I'd go that far, having been through Y2K, but it's pretty comparable in many ways. So, but there are a couple things about ICD-10 I just want to kind of point out. And one of the themes I use around ICD-10 is that, in some respects, ICD-10 is bigger than we thought it was. And we're learning a lot about ICD-10 as we go along. I know that maybe people feel a little uncomfortable about that, but the fact is that we're learning about the practical impacts of ICD-10 as we go along. We do our impact assessments and so forth. And we're going to continue to learn about it as we work through these projects. So in the beginning, we thought, well, ICD-10, it's going to create a change in the codes that are put on the bill. You're going to send that claim in. The health plan is going to have to make changes in the diagnosis codes that are used on all the bills, okay, and of course the procedure codes, because only the procedure codes are changing in the inpatient, setting for inpatient visits. So a lot of change there, but still, in the beginning we thought it was kind of contained a little bit, and then now we're starting to see, hey, that actually, you have to submit a diagnosis when you do an authorization. The coding is dependent on clinical documentation. The health plan does get that claim and adjudicates it, but what do we do with that information? We do a lot of analytics around with that information. So we figure out HEDIS scores. And how do you figure out a HEDIS score? Well, you look back at diagnoses over a 2-year period, okay, to determine whether people are getting the right kind of services. Well, what do you do on January 1, 2014 when you have 3 months, roughly 3 months, of ICD-10 codes, diagnosis codes, and you have the previous 21 months before that of ICD-9 codes? Well, how are you going to marry those things up, and so forth. So the changes are very significant and much broader, I think, that we're appreciating. I think we're going to even see this kind of, and I'm sure you could probably put a million other boxes on here of things, but we're going to see a lot more as we go through and we learn of changes and where there are touch points that we don't appreciate today or we don't appreciate the impact of. At the same time, ICD-10 is it's not as big, okay? So we look at those codes, oh my gosh, all of those codes, and finally somebody asked the question, well, how many do we really use today of ICD-9? And so somebody did a study here, stealing some slides from Mark Williams at PricewaterhouseCoopers, and found that, really out of the 13,000 codes that are used today for procedure, we use really about 2,800 for this facility, 1,200 for that, around diagnosis codes. So we don't use as many codes as we think we do, honestly. So what's going to happen with ICD-10? Well, probably about the same thing. There are going to be places where we use more codes, no question about it. But, there are going to be places where we don't use a lot of codes. So what codes you use, they're going to depend on what we call your case mix, right? So your case mix at John Peter, kids, primarily, right? Some of those codes don't apply to kids, okay? A lot different than maybe a Christiana Care, where you're the only level 1 trauma facility between Baltimore and Philadelphia, where, there's a lot more, potentially a lot more codes used. We're a Medicaid health plan, kids and moms, okay? Are we going to see all of these codes? We're going to need to focus, and we need to be prepared to deal with all the codes, okay? But where we need to focus in terms of our training, our analysis of financial impact, our analysis of processes in informatics is probably on a much more limited set than we had originally thought, okay? So, because that's the reality of the patients and the care that we deliver, okay? So, on the one hand, ICD-10 can be viewed as getting bigger, but to be honest, we're trying to, in some of our strategies, make it smaller and contain it and focus it on those things that are really going to have an impact from a code standpoint. So you just can't say, well, it's 10 times the number of codes that we had before. Which, you have to look at it specifically in your specific case and how that's going to impact you. So that's ICD-10. I don't want to go over a whole lot of detail around it, but it is a huge initiative, and it's one that is probably having a more, and we'll see this later, a little bit more of a pivotal effect, I think, around all of our initiatives than maybe some of them. Okay, if you're This is the recommended, and I can't believe that anybody is really where they need to be on this, but I hope you're as far along as you can be. Recommended schedule for ICD-10. Okay, you can see right now, you should have completed impact analysis and your budget, have your budget and your requirements out there. 2012 is that year where we need to be making all of these changes to our systems. Okay, so on a health plan side, what are we doing? So we have one system that takes the claims in, determines whether they will apply our rules, our health plan rules to them, and then determine whether you're going to get paid and how much you're going to get paid for that particular claim. Huge system, okay? It's our bread and butter, okay? That system, we're going to upgrade that system in 2012. Our medical management system for authorizations and care management. We're going to upgrade that system in 2012. Those big systems, I think we definitely have on the radar screen in terms of making sure that they are going to be compliant by the end of 2012 so we can do testing and so forth in 2013. What I think some of our challenges are, and many challenges, there's so many other little systems that fit in with that, okay? And getting those systems up and running and converting, getting those vendors to deliver on time their ICD-10 upgraded applications, I think is going to be a real challenge. And then, of course, being able to test and have enough time to test will be a challenge as well. So that's the ICD-10 timeline. One of the things that I worry about and lose sleep at night over a little bit is the impact of 5010 to ICD-10, because when I talk to organizations, while the plan is to go, and I believe CMS might have a little bit of a contingency period, but not a whole lot. I think it's going to go 1/1/2012. Maybe providers might get a little bit more of a window. I don't think health plans are going to get much more of a window. But the challenge is when I talk to organizations, that a lot of the folks who are working on ICD or on 5010 are the folks who are also going to be working on ICD-10. Okay, now. And when, as the resource managers go through and they determine when, okay, Joe's going to be available Q1, okay, of 2012 to work on ICD-10. Well, we run into some problems on 5010. Now Joe's not available Q1. Maybe Joe's available to Q2. Maybe he's not available to Q3. Well, what's that do then to the ICD-10 initiative? Now you can say, well, let's go out and buy, just buy another Joe. But one of the challenges we have with these initiatives, and I think many of you are probably pretty aware of this, there are resource managers and so forth, is that finding people who understand healthcare, not to mention healthcare, the complexity of some of the healthcare transactions and those components, really, sophisticated components in healthcare. Information technology is very difficult. Okay, we're not seeing, there's just not a lot of folks out there. And so, the ability to bring somebody in who understands the impact of 5010 or ICD-10 or these other initiatives and is ready to hit the ground running, whether they're a VA or a programmer or an architect and so forth, we're very limited in that regard. Okay, so that's one of the things that keeps me awake at night, because I think that we're going to see our ICD-10 plans get delayed a little bit the longer it takes us to settle 5010 down. Now, second initiative, one you're well familiar with, I'm sure, is the HITECH Act and EHR Meaningful Use. And I won't go into the details of that, but I know that we're all getting our electronic health record systems up, and it's a challenge. And it's a challenge to get all of those components. And I know that you've done a great job here at CHOP in terms of doing this. But the meaningful use requirements, okay, remember, come in stage 1, stage 2, and stage 3. And the stage 1 requirements are out there. Everybody's trying to achieve those. Everybody has their gap list and so forth. Hopefully you're close, you've attested or you're close to attesting, to meeting those. But stage 2, okay, the bar is raised significantly as we see it today. okay, for stage 2 meaningful use. In other words, to be able to get those incentive dollars, okay, what's going to happen is that you're going to have to meet a new list of 25 or 30 standards, okay, that, you know, the Health IT Policy Committee, I think, has recommended now to ONC. But one of the things they said, okay, when they made that recommendation to ONC was, guys, let's delay this a little bit, okay? Because remember, stage 2 meaningful use is supposed to go 1/1/2013. Well, 10/1/2013 is ICD-10, okay? And one of the things we've seen through surveys, and I'll show you a little bit of this later, is that there's a lot of competition for resources between the EHR Meaningful Use projects that are out there and the ICD-10 projects, okay? Hey, come on, if I were on the provider side and I'm the CFO, I'm saying, hey, you're paying me money to do this one, okay, EHR Meaningful Use, so I'm paying a lot of attention to that, okay? You know, you look on the ICD-10, it's like, oh, what's that about? You know, they're not paying me anything to do that. And why should we move as aggressively on that? Or if I have, you know, Billy Bob, who is, you know, this great IT architect, well, what project am I going to have him work on first? I think it's going to be meaningful use. So there's been a lot of competition between these two initiatives moving forward. The feds, I think, have realized that, and now I do think that they will probably push off stage 2 meaningful use to 2014. That's only 3 months after ICD-10, but it does hopefully give a window for ICD-10 to move forward and try to stay on schedule. So EHR Meaningful Use is an enormous initiative you're very familiar with. That's kind of the take on it that I have right now. Now, a real exciting component of all of this change is around what I call health information exchange. Now, don't confuse it with health insurance exchanges, okay, which are really part of healthcare reform. Health information exchange is being able to securely share patient information across healthcare organizations. And you probably do that today within your own organization, you know, the overall TIN for CHOP, so you share information between the facility and the ambulatory side. That's great, okay? The challenge is, how do we share it with other facilities? How do we share it with other physician practices? How do we do that securely, you know? And you know, with ensuring that we're, you know, maintaining privacy and so forth. So, you know, but there's some great use cases out there for why we should do this. Labs to PCPs, we're probably doing a good bit of that today. But let's take summary of care. This is in one case. I'll show you an example. We, as a health plan, have a great summary of care record that we share today through a portal. Okay, with our providers. Okay, but through a health information exchange that can be distributed much more broadly and widely to the point of care where it really can make a difference, I think. Discharge information to home health. Okay, you know, it's interesting, as part of our health information exchange effort. About a year ago, I did like a little tour of PCP practices from various various organizations around the area, and you know, I said, well, now when does the hospital fax you? What do you learn about that Joe Miller just left the hospital? Okay, and they say, well, when Joe makes the phone call for his follow-up visit, you know, to the practice. And I said, well, and they say, and who knows whether Joe's going to do that or not? It depends on how compliant he is as a patient and so forth. Well, you know, the fact of the matter is that if we're going to achieve some of these objectives in terms of payment, form, and all that kind of stuff, you know, we can't rely on Joe to make that phone call, or for the physician practice to wait for Joe to call them, okay, to set up the visit after Joe gets out of the hospital. Okay, so there's a lot of scurrying around now to figure out ways that we can share information effectively to address that kind of use case. So, you know, here's one example of what we do as a health plan today. Now, why would we do this as a health plan? Well, as I say, you know, 99% of the time, our, you know, objectives are aligned. Okay, so we want you to understand, as a provider, we want you to see as much of the patient care that's going on, you know, for that member. So in this case, what we're doing is we're sharing that broad view of information on what are the medications, what are the visits, what are the care gaps that this particular member, what are the labs that this particular member has. And you can say, well, we know that, okay, lots of times. Well, absolutely you do, particularly in a great health system like this, where, in a lot of cases, your primary care physician is part of your system, your hospital, activity is part, all within the same system, and you can share that information. You have great electronic systems to do that. But we're in a region that is not very monolithic, okay? I think there's 49, 48 acute care facilities in this 5 or 6 county region, 600 and some thousand discharges a year, and the statistics from the Delaware Valley Healthcare Council indicate that there is only one health system, University of Pennsylvania, that has more than 10% share of those discharges. So when you look at a pie chart of all the discharge in all the facilities, boy, I'll tell you, you're going to starve if you had to eat one of those pieces of pie, because they're very, very, very thin, And what that means then, of course, is that, the person who went for the back pain to the temple and was discharged from the ED, or maybe an inpatient stay last week, may end up at Jefferson next week. Jefferson has no idea they're there, and so forth. So that one of the benefits of the health plan is that we know, that we see that all of that across the board for our members. Now, one of our problems too is we only find that out when you guys send in a claim. That's not always. It's pretty timely. Actually, it's improved a lot, but it may not be timely enough to really improve care as much as we'd like it to. So, but we try to do our part in terms of sharing information out to you. And part of the health information exchange effort really will look at how do you share information, back to other providers and to help coordinate the care of this particular member. So challenges, it's costly, okay, to do this. Privacy challenges, competitive interests, obviously, and in the past there's been no incentive. Well, I think a lot of that's changing. There's a Commonwealth initiative around, in our local initiative here, and Dr. Liberty is very involved in both of those initiatives to number one, set at a state level what we need to establish at the state level. What do we need the state to do? What I pray that the state does is they give us one form for consent, okay, for sharing information, okay, because, in our local health information exchange, if they don't, that means I'm going to have to go around to 49 compliance officers and try to convince them, each one, to use this one form. Probably not going to happen, right? So if the state can set the rules of the road that we all agree to in terms of how we share information and when we can share information, that would be fantastic. And would take care of that privacy component. Competitive interest, used to be a big factor too. But now I really think that most of our facilities, when I go around and talk with folks, realize this is not something we want to compete on, sharing information. There are lots of things we can compete on in terms of this, how we package our services and so forth, and deliver care, okay? But sharing information is not something we should compete on. I think that's out of there. And when we look at incentives, financial incentives, okay, we're really looking at incentives now, financial incentives for that come out of our health plans. Our health plan, for example, people talk about ACOs and all this kind of stuff. We're writing contracts today that have provisions that incent providers not around how much care you deliver, but what the quality and the outcomes are of the care you deliver. Okay, so there are contracts being written by some payers, around shared savings. Okay, to reduce the number of preventable readmissions. Okay, all kinds of different methods for doing that. So I think the incentives are now aligning as well. Okay, around how we pay for services, and now health information exchange is seen as a critical component of that incentive, those incentives, not as something that stands off on the side. So a lot of going on, very excited with what we're doing here in southeastern PA. We're going to be looking at this use case that really looks at a hospital delivering information to an HIE, and that HIE pushing information out to PCPs and practices when a discharge happens, not when a discharge summary gets signed, okay? Because we all know that takes 5-7 days, I don't know, depending on the facility. But when a discharge happens, how do we push information out as quickly as possible to the care team that needs to see that information so they can deliver the appropriate follow-up care and prevent that readmission from happening? And that care team we need to look at broadly too. It could be home health, it could be the care manager at the health plan, it's certainly the PCP, it could be the specialist, it could be several specialists where that information needs to be delivered in a timely basis, not 3 days, not 3 weeks afterwards, not when the patient goes and calls the office, but within 3 hours of the discharge, so that the team, the care team, can start preparing to deliver the follow-up care that will prevent that readmission. So that's one of the great use cases I think we have here. We're real excited about it. We're working with the state, we're working locally to try to move this particular use case forward. Another component, this is component number 4, the Affordable Care Act, Section 1104. Affordable Care Act was health reform. As we, and it's interesting as you talk about, look at health reform today, there's all of this discussion about the individual mandate, okay? But probably, 90% of the act was about how we improve quality, how we improve efficiency, all of those pieces, and all of that stuff is being done today in many, many, many states, okay? For one of the sections was around administrative simplifications, however. And so this section that has some real potential benefits, I think, for providers, and some real headaches for payers, and you'll see why, sets operating rules for how we do HIPAA transactions. Now, probably not a lot of financial folks in the room or people who maybe deal with that aspect of it, but effectively, as you guys send in claims, those are great, but you want to get electronic remittances back, okay, that you can automatically post to your patient accounting system with all the payments, instead of having somebody sit there and key them. Some health plans provide that, some health plans don't. Some health plans provide it the right way, some health plans don't. Drives your folks crazy, okay? Operating rules, the intent of the operating rules is making all health plans do it the same way, okay? Deliver the HIPAA transactions in a way that is consistently usable by providers. So the Affordable Care Act says that HHS will establish operating rules this year for eligibility and claim status, which will be required to be compliant with by 1/1/2013. ERA and EFT, they have to put the regs out next year for compliance by 1/1/2014, and enrollment, payment, and authorizations by 1/1/2015. So they have expedited rulemaking authority to do all of this. So the interesting thing is really two interesting things about this. Number one is that it requires that we certify, health plans certify that they comply with this. Well, we've never really had to certify that we comply with HIPAA. I mean, the test of whether you're HIPAA compliant or not is that somebody can take your transaction and actually, use it. And then if they can't, then they get to write a complaint, and I think the maximum penalty on those complaints or something like that, if we were found not to be compliant, would be like $25,000 or something like that. For most health plans, a drop in the bucket, let's face it, for many large provider organizations as well. So now we got to go with certification. So we've got to certify that we're not only HIPAA compliant, but we're complying with these new operating rules that create much more refined standards for us to deliver the information in a consistent way to the providers. Not only is certification there, but there's a penalty. And this penalty will hurt, because the penalty for non-compliance is $1 per member per day up to 20 days. Well, for a 1.3 million member health plan, that's a potential penalty of $26 million. That's a lot of money. That gets the attention of a CFO in the health plan okay? And they're going to say, you know, hey guys, we're not going to get any of these penalties. You're going to make sure you get this right. So a lot of attention is happening with this around on the health plan side, and the penalties apply to health plans that don't apply to providers. So in other words, health plans are being required, and it's a great thing, you know, to deliver these transactions much more consistently in the future, okay, for providers to then take advantage of when they're ready to take advantage of. So huge change, has a big impact on the health plan, but it has a great opportunity there also for providers. So then the final item, and I'll wrap up here and hopefully leave a few minutes for questions, is around health and payment reform. You know, and again, as I mentioned earlier, we're paying out, you know, whether you think accountable care organizations are going to work or not. My vote is not as they're currently laid out. I don't think they're really going to work. Whether you think they're going to work or not, all of the components that underlie accountable care organizations in terms of payment mechanisms and so forth are being applied in some way today and are evolving very quickly in the contracts that our CFO and your CFO, you know, agree to. Okay, so there's much more based on, you know, outcomes, performance, and so forth. Much less based on we did, you know, 300, you know, of these this past month, and we're billing for. So you know, health reform may go, you know, ACOs may not materialize, but payment reform is here today and will continue to evolve as we move through the future. And that's going to create a lot of change also in how we deliver care, how we pay for care, and the technologies we need to be able to monitor that and determine whether we are, in fact, doing what we need to be doing, and, you know, it's hitting the bottom line. So what are this, you know, so let's go back. We got ICD-10, we got EHR Meaningful Use, got operating rules, health information exchanges, health reform, and all these huge initiatives out there, and they all look different. They all look separate. Do they relate to each other in any way? Well, it's interesting. A lot of people see them as pretty competing. Okay, so we did a survey, 250 hospitals through HIMSS, and we asked, what's, you know, for ICD-10, what's getting in the way? And 66% of the folks came back and said, EHR Meaningful Use is getting in the way. Okay, can't get the attention of CFO, can't get the right resources, okay, I can't get my ICD-10 project done because of EHR Meaningful Use. Okay, understood. Then we also had another question, and this is kind of a little bit counterintuitive. It asked, well, what's your approach for ICD-10 compliance? Most people are going to upgrade, okay? A lot are going to use a crosswalk. Wait a second. 33% said they're going to leverage their meaningful use efforts for ICD-10. Well, how would you do that? You know? Well, okay. What have we talked about ICD-10 depending on documentation? Okay, electronic health records, you know, are documentation systems in part. Okay, so some people are obviously connecting the dots on those, and they're saying these things kind of go together. You know, they make sense. If you look at the physician practice side, okay, I'm a practice, and I'm going to go out and I'm going to buy a new electronic health record system. You know, unless I'm a big, you know, teaching practice or something like that, you know, with hundreds and hundreds of docs, I'm going to make sure that that new electronic health record system is really tightly integrated with my practice management system. Okay, so now I'm going to get rid of that old practice management system because we're going to bring a new electronic health record system in together with that vendor's practice management product that is going to be a lot closer to ICD-10 compliant than that old system that I had. So organizations are looking at these kind of ties between ICD-10 and EHR Meaningful Use in ways that they can leverage because they can't afford two different separate complete projects, okay? Or at least 33% of them are looking at this, okay? And I think that number is actually starting to grow a good bit. So, and then if we look at this slide, just to try to, how do these pieces, these 5 pieces kind of tie together? And this is just some initial kind of thinking around it. which, you know, if you take ICD-10, well, that provides changes. And, you know, to achieve ICD-10, you're going to need to upgrade your, you know, your practice management system or your hospital information system that does your billing and accounting and so forth. Well, you know, that's going to kind of, you know, probably put you on a version that may enable you to leverage some of those improvements that come from administrative simplification. We've already talked about EHR Meaningful Use supported by ICD-10. Health information exchange. We talked about how, from a business standpoint, okay, the improving information exchange and the continuity of information across care settings with health information exchange would be supportive of improvements in outcomes, which is what you're going to start getting paid for. Okay, EHR Meaningful Use, obviously the same thing, and so on. So these pieces all start to come together. We need to be looked at as a whole to see where they can be mutually leveraged, okay, to enable them to be, you know, effectively deployed in a meaningful way for the organization, meet its objectives at the lowest possible cost and effort. So instead of, and I'm sorry because we're all sick of water now, I know, and you know it was the perfect storm. I think of it now almost as the perfect wave. How do you ride that wave of initiatives in a way for your particular organization, which taking where you are today and where you want to get to, and with all of these initiatives on your plate, how do you ride that wave, you know, to be as effective as possible in delivering all of these pieces? And I think one of the first steps in that is looking at all of these pieces together to see where their touch points are, where these 5 big HIT initiative touch points are, and then how they can be leveraged for your organization to improve care and meet the needs that you have. And then the last thing that I would just say is, I always end this, everybody knows who Henrietta Lacks is, you know, and Henrietta Lacks donated cells that were used in an enormous amount of research called HeLa cells, and she died, I think, in 1951 at Johns Hopkins University. And the tragedy for Henrietta Lacks is she donated those cells without her consent. And as we all work through all of these huge HIT initiatives and so forth, you know, privacy of patient information and consent and so forth is critical for us to be effective, because if we lose the confidence of the public in our ability to protect their information, okay, all of these initiatives will be set back significantly.